Thanks very much. So, some of you may know me from emergency, but now I have this other role in the Ottawa Hospital as medical lead. And part of this is to work on end-of-life care and conversations. And so I'm really happy to have been asked to talk to you today about this, interventions, challenges, discussions around end-of-life. I apologize to those of you who may have heard me speak last year on a similar topic, but I was given the same title, so some of this hasn't changed. However, there are a few new twists around this. I don't have any conflict of interest because nobody ever gives any money to ethics. Our objectives today are to know what we ought to do ethically and morally around end-of-life interventions, to know the rules so that we're staying inside the law as far as this is possible, which is not always easy, as the law and ethics are not the same thing. And sometimes the ethical thing to do is not the legal thing, and vice versa. And then we add in the 2016 College of Physician and Surgeons policy on end-of-life, and that makes it even more confusing. I'm going to talk about a couple of tools that we can use to structure conversations about ethical issues around end-of-life, and touch on some challenges using cases that are either composites or in the public domain, so no confidentiality is challenged by using this. And then a brief update about MAID, bearing in mind the recent 600-page plus long awaited recommendations from the Council of Canadian Academies. Why do we need to talk about end-of-life? Because a lot of the time, nobody else does, and by the time patients come to us, we assume that someone's talked about it, but nobody actually has. The concern is that patients get interventions that they don't want, or they don't get the interventions that they do. You may recognize this person, certainly those of you from Kingston will. Darren Hayward, an intensivist in Kingston, director of CareNet, Canadian Researchers at the End of Life. And a few years ago, he hit the national headlines with his cross-Canada study of 1,400 end-of-life patients and families, looking at what they actually wanted and what they were slated to receive at end of life. 35% of patients were labelled as wanting a full code when actually they didn't. And perhaps slightly more alarmingly, 8% were slated not to receive any resuscitation when they in fact wanted a full code. Earlier research of his, he actually looked at what patients did want around end of life. Mostly they wanted to have trust and confidence in the doctors who were looking after them. Also to have honesty in their disease communication, to be treated with dignity, and 84% not to be kept alive on life support when there is little hope for recovery. So who needs to talk about this? Well, just about everybody. Who needs a goals of care discussion? It might take 60 seconds in the relatively healthy 72-year-old admitted for gallbladder surgery, but we don't see those patients. We see the complicated patients who need a much more in-depth conversation. We all know the surprise question. Would you be surprised if this patient doesn't survive? And of course, you also have your frailty indices that you rely on to identify patients who are at higher risk of death. And now in the hospital, we're introducing Homer Now criteria for identifying high-risk patients that need a much more in-depth discussion. But how do we actually do this? First off, we're going to look at two tools to use when we talk about end of life: a checklist and a conversation guide. And to do this, we're going to revisit my old friend Frida, who some of you may remember when we talked about this a year ago. Frida's 89. She lives on the memories floor of a very, very nice retirement residence with her second husband, George, and George has dementia. She moved there to be with him. She has a son and a daughter-in-law who live nearby, and they drop in occasionally when they can. She has a stepdaughter, George's daughter, who visits frequently, is her main caregiver. And she has a son who lives in California who's a doctor, because everybody in an ethics case needs a doctor living in California. She's been admitted to your unit because she's been falling a lot and she's declining. She can't walk, she's incontinent, she has pressure sores. She can feed herself, but she can't dress. She used to read, she used to do needlework, she can't do that anymore, so she spends her day in her wheelchair, propped up in front of Days of Our Lives. The retirement residents can't cope with her anymore, despite the fact that the son in California is paying a lot of money for extra care. Yet again, she's fallen while she was trying to transfer, despite the fact she's been told not to, and is sent to hospital. She has diabetes with all the complications, hypertension, coronary artery disease, aortic stenosis with CHF requiring several hospital admissions so far, COPD, arthritis, can't walk, some cognitive impairment, she's overweight, drinks alcohol, and still smokes when someone will take her out for a cigarette. Would you be surprised if she survives the year? She continues to decline. The residence doesn't want her back. She's waiting for a nursing home bed. Time passes. She gets depressed on the ward. She stops eating. She stops drinking. The CHF worsens. Someone, somewhere along the line, suggests a referral for a TAVI. Let's fix that valve. You stabilize her as best you can. Essentially, she's got end-stage everything. She continues to decline. You do some lab. Her creatinine is going up and up. You call a family meeting to discuss goals of care. And this is what you get. George, the husband, who you remember has some dementia, is, I don't know. Jim and Maggie, the son and daughter-in-law, who drop in from time to time, are, oh, you gotta save her. Got to send her home, do that surgery, fix that valve, dialyze that creatinine. She maybe will need a ventilator. Put a feeding tube in, she's not eating. And if her heart stops, well, you can do all kinds of magic things. But Sarah steps in and says, I see her all the time and she doesn't want any of this. She knows. And you call Ian in California and he said, a TAVI? Dialysis? Are you insane? Haven't you heard of PATH? And you guys know much more about PATH than I do. But Ian also is the one who's paying all the bills, so maybe he has two dogs in this fight. It all looks very, very familiar. So where do we go from here? And who is actually missing? Whose voice is missing from this conversation? And this is a difficult situation because really, she's end-stage everything. But everything is a little bit temporarily fixable. Dialysis would help her fluid overload and her cognitive status when her urea comes down. Maybe cardiac surgery could do something about her valve. And maybe we do have something to offer for her depression and her not eating. Here's the first tool. What can we do? And more to the point, what should we do? What are our end-of-life ethical obligations? This is the first tool, the checklist for meeting ethical and legal obligations at end of life. It comes from William Osler. Is the patient capable? If so, what do they want? And are those wishes realistic under the current medical circumstances? If she's not capable, who do we talk to? Has the patient chosen the power of attorney, or do we have to figure out? And does that patient or does that person know how to be a substitute decision maker, what the rules are? Because there are rules under the Healthcare Consent Act. Has the patient ever done any advanced care planning? Are there directives that the SDM can base the decision on? Or do we have to look out for what the patient's best interests are? And what actually is a best interest? Then we use that information to discuss goals of care, propose a plan, get consent, and then we have to deal with any disagreement that might arise. Sounds easy, right? Why is this important? I'm not going to talk about consent. Just to say that we need to get consent from someone, it's got to be the right someone. It supports patient autonomy and self-determination. Legally, it prevents us from committing an assault and getting arrested, and the CPSO has a policy supporting it. So first, is the patient capable? Do they have capacity? And if so, what are the wishes? This is basic stuff. In the absence of evidence to the contrary, the patient is presumed to be capable. The concern with geriatric patients is this creeping paternalism, the unspoken and unrecognized tendency for us to infantilize them. It's benign, but it robs them of their autonomy. It's influenced by their living situations, kids acting like their parents' parents, this sort of relaxed confidentiality. They're brought to their appointments by their family, and so we treat them as if they lack capacity and talk to the family without even talking to them. And at the risk of laboring the point, it's the responsibility of the person proposing the treatment to assess the patient's capacity. It's not GEM, psychiatry, social worker, it's the person proposing treatment. Other people can help, but it's down to us. Capacity is the ability to understand the information that you give them, that's cognition, and appreciate the consequences of making a decision, that's reasoning ability. Not based on delusion or depression and abiding over time. So Frida, who you remember is cognitively impaired, is not necessarily incapable. She needs to be included in the conversation and her capacity assessed. Excuse me. But Sarah, the stepdaughter, says that she usually takes mum to her appointments and makes all her decisions for her. That in itself is not a diagnosis of lack of capacity. Some families just do that. They haven't read that Healthcare Consent Act. They don't know. But you've interacted with the family for a few days. You're satisfied she can't understand the information. So now, who do we talk to? Who's the SDM? And do they understand their role? The other thing is that SDMs only become the decision maker when the patient no longer has capacity. We get people saying all the time, I'm the power of attorney. They come in waving that document when the patient has full capacity still. Doesn't matter, that power of attorney has no legal standing to make decisions until the patient lacks capacity themselves. This is the hierarchy for substitute decision-making in the Healthcare Consent Act. You probably know this or have seen it. You go down the list, ranked in order, until you find somebody on that list to make the decision. And if you can't find anyone, not even a long-lost cousin in California, we resort to the public guardian and trustee's office. We all, by law, have a substitute decision maker or are a substitute decision maker for somebody. And if you don't like the person on that list who's going to make decisions for you, then you go out and make a power of attorney, and then that power of attorney that you have legally chosen goes to the top of the list as an attorney for personal care and outranks everybody else. So Sarah, the stepdaughter, says she's the one who takes Frida to appointments, but unless the spouse who outranks a child, that's George the husband, is no longer capable by reason of his dementia, Sarah is not the person who's going to make those decisions. And unless Frida has chosen Sarah to be power of attorney, it's Sarah and the two brothers together who are the equal decision makers. The SDM themselves has to be capable, available, and willing. So you have to make a reasonable attempt to find Ian by phone from California. They have to be willing, so they have to be able to decline the job if they want to. And it's not our job to referee the 15 squabbling siblings. It's our job to find out what her goals and values are, to offer treatment in accordance with this. And if the family who rank equally do not agree, you can't talk to the one who's the most reasonable. You can't just talk to the one who agrees with you. If there's no consensus, we apply to the Office of the Public Guardian and Trustee. Often the thought of the decision being taken out of the family's hands is enough to make them agree, because nobody wants someone else to make decisions for them. How do they know their role? How do people make substituted decisions? There are rules. Most SDMs don't know this, and they're very relieved when we tell them. So this is where the advance directives come in. If the family know what Frida would want in this specific situation, or if she's given direction, then they have to follow it. If there are no known wishes, then they look out for her best interests. So we don't say to the SDM, what do you want? It's got nothing to do with what they want. Then we run the risk of the SDM directing the care plan. We ask, has Frida done any advanced care planning? Do you know your role, which is to act on this? And if there are no advanced wishes, we can talk about her best interests. Okay, plug for advanced care planning. All you and your patients ever need to know about advanced care planning is Speak Up Canada, which is a cross-country initiative which you all know about and you all use, I'm sure. But the huge problem with ACP is you can have the most perfect plan in the world, and if it's at home in a drawer or in the lawyer's office, it's no use to anyone. The other thing is the confusion about the lack of legal status of advanced care planning in Ontario. Advanced directives have no legal standing. Unlike in Alberta, BC, and most of North America, they're not direct pre-consent or pre-refusal to a medical procedure that is not yet being proposed for a disease that does not yet exist. What they are directions to the person who will be providing consent, and that's the SDM. If you look at the new Speak Up workbook that came out last year, it's moved totally away from a list of do this, don't do that procedures to defining values that are important to the patient and choosing a substitute decision maker and encouraging conversations between the patient and that SDM. so that they know what's important to the patient when they have to make a decision for them. Advanced care planning and goals of care get muddled together. ACP is done by a healthy patient planning their wish list for what they'd want in the future if they become sick and can't speak for themselves. And goals of care is when medical realities set in, they become sick, and the SDN then uses that planning, those advanced directives, those advanced wishes, as a guide for what they'd want within the confines of what can be offered. So it's not a substitute for consent, it's not legal directives in Ontario, it's just a guide to the SDN as to what the patient's wishes are. The doctor has a goals of care conversation either with a capable patient or with the SDM, proposes a treatment plan, gets consent, and then comes up with care plan, goals of care designation, code status, whatever is needed. Another really important part of your advanced care planning is determining what circumstances would change that person's goals and wishes. 10-year-old expressed wishes might not be currently applicable. Medical interventions and possibilities might have changed, and patients' attitudes might have changed. So it's a constant evolution, it's a constant conversation. That's why it's planning and not a directive that's cast in stone. So Frida, like most of her peers, didn't have any written advance directives and hadn't expressed herself clearly enough for verbal comments to directly apply. So the kids have to make a decision that they think will be in her best interests, and nobody knows what a best interest is. According to the Health Care Consent Act, these are the criteria that we have to consider. The values and beliefs that she held when she's capable. Any wishes that she may express while she's incapable, so her current incapable wishes. The benefit and burden of the treatment that you're suggesting, and whether a less restrictive or intrusive treatment might be equally as good. And we talk a lot about values and goals, but we really have a hard time teasing those out. And this is the second really important tool, the Serious Illness Conversation Guide. This is a great validated conversation tool developed by Ariadne Labs in Harvard and the Dana-Farber Cancer Institute. The Department of Internal Medicine here is rolling out training sessions on this over the next few months. It's designed for developing goals of care with a patient who has an ongoing but life-limiting illness. It's also intended for use with a patient who has capacity, but it can be modified to talk to families as well. It uses scripted language, patient-tested language, to set up a conversation, to introduce the idea of decision-making, to assess understanding and correct misconceptions about the patient's disease process, and to share the prognosis, framing it in a wish-worry, hope-worry conversation. It explores key topics, goals, fears, worries, sources of strength, critical abilities, and trade-offs. The key question, the key statement is, how much are you willing to go through for the possibility of gaining more time? And it can be modified for families as if your mother would speak to us now, what would she tell us about her fears and worries? If you're talking to family, you can add, did she ever speak to us about this kind of situation? What did she say? I.e., are there any previous capable wishes that would apply to this scenario? Then you close the conversation by summarizing, I've heard you say that X was very important to her. Keeping that in mind and what we know about this illness, I recommend that we do X. We propose a plan. This will help us make sure that her treatment plans reflect what is important to her. And so this, they say, is being rolled out right now at TOH, and we're hoping that it catches and it spreads because it seems to be an excellent tool. And here's another idea where it can come up stuck. We propose a plan. Not the SDM proposing a plan. It's patient-centered care, but it's not patient-driven care because what they're doing is they're consenting or not to the treatment that's being proposed. We're going to do what will benefit Frida, and we'll continue the treatments that are indicated in her best interest, which could be anything from comfort care to dialysis and that TAVI, depending on where the conversation takes us. We're not going into the goals of care conversation with the intent of getting the DNR. We hear this so often, I'm going to get the DNR. That is not the intent of this conversation. The SDM either then gives consent to or declines the treatment that you propose. And then, what if there is no agreement? It's a challenge that we can't reach agreement, but we have resources that can help us. There's a conflict resolution process. Guidelines on MyTOH and patient advocacy. You can get help from spiritual care, ethics, social work, legal, patient advocacy. And if all else fails, you can apply to the Consent and Capacity Board, which is a presentation unto itself. The CCB is a tribunal authorised under Ontario provincial legislature to rule on disputes over capacity and whether the SDMs are making a decision in the best interest of the patient. It's not user-friendly. It doesn't always rule the way we would expect it to, but it is our last resort. So you're sitting in the family room with the social worker and the family and are gradually coming to the consensus that Frida likely wouldn't want any major interventions. Code blue, Frida. You run there with the family. Oh, doctor, you must do something. Do CPR, that will save her. I've seen it on TV. So you know that your likelihood of success is not very high. And you know that your likelihood of CPR actually providing benefit to Frida is minimal. But the family, her substitute decision maker, are asking you to do CPR. They're asking you to perform a procedure that you think is not going to benefit her in any way. So let's leave Frida and her family in limbo for the moment. And while we're talking about conflict, let's move on to some disputed advance directives that led us towards college policy. Which brings us to futility. We don't have any obligation to provide treatments that are futile, that are outside the standard of care, or treatment that just won't work. But those ventilators, dialysis, feeding tubes, they just do keep on working, in that they physiologically do their job. It's just that we question whether they are of benefit to the patient. When we do that, essentially, what patients' families are hearing us say, they're hearing us say, well, I don't care why you want to keep mum going. I think it's wrong, so I don't want to do it. My values are right, yours are wrong. We, system, gets to decide what diminished means. And with all the conflict resolution in the world, one side is going to lose. That's what the patients hear when we get into this kind of discussion. Unilaterally withdrawing care can be regarded as discrimination against the patient on the grounds of physical or mental disability or religion. And these are the charter arguments that the lawyers use when these cases end up in court. And there have been a couple of high-profile cases that have changed the end-of-life landscape, which I'll touch on briefly because you probably know some of these. Let's talk about the legal and policy part. I can't talk about college policy without talking about Mr. Rizzulli and Mr. De Geer. That's how we got there. You probably know all about Mr. Rizzulli, but not Mr. De Geer. Mr. Rizzulli developed encephalitis after surgery for a benign brain tumor and entered a persistent vegetative state. His doctors decided it was futile to continue his ventilator and intended to discontinue it. It was much more than that. I'm minimizing this. There was a lot of other issues. They felt that he was suffering greatly. They felt it was harmful for him that they were causing him harm to continue in that state. It wasn't just a futile argument. But his wife objected to this, and she got a court order to prevent them removing the ventilator, and this went all the way to the Supreme Court. And the Supreme Court eventually said that the doctors should have obtained the family's consent for withdrawal of care, or should have gone to the Consent and Capacity Board if they felt she was not acting in accordance with the rules for substitute decision-making. Even if they had gone to the Consent and Capacity Board, it's very likely that the board would have found against the doctors because she was actually acting in according to his wishes and his values, because according to his wishes and his religion, his values were for life at all costs. So she was pursuing that on his behalf. Mr. De Geer ignored advance wishes. The momentum for the new college policy on end of life. Around about the same time, he went into hospital for an amputation. He was 88, he had congestive heart failure, hypertension, COPD, diabetes, dementia, and peripheral vascular disease. This is Joy, his daughter. She was a nurse. She was his substitute decision maker. And she'd initially agreed to have a DNR on his chart as he had expressed previous capable wishes not to be kept alive by machines. Sounds very clear. After his surgery, she requested this be changed to a full code, and it was. Not sure why. First stage of ignored advance wishes. He deteriorated to the point that CPR was considered futile. And the doctors changed him back to a DNR, but they didn't ask or tell Joy that they were doing this. They intended to. They left a message on her answering machine asking her to call them, but unfortunately, before that happened, he had a cardiac arrest, or respiratory arrest. Even more unfortunately, she arrived to visit him while this was going on. There was no code. He died. She tried to bag him herself while this was happening. You can just imagine the scenario. He died. She complained to the college. They upheld the doctor's decision. It was futile. There's no obligation to provide futile CPR. They criticized the communication skills. She appealed to the Health Professionals Appeal and Review Board, who told the college, look again at your decision. They did. They exonerated the doctors again. There was no obligation to provide futile treatment. Back to the review board. And around this time, the Rizzulli Supreme Court decision came out. The board conflated that decision about consent for withdrawing care with consent for not providing care that would be futile, and basically told the college to change their policy to comply with this. So this is where we have the CPSO end-of-life policy at the moment. No unilateral withdrawal of life-supporting treatment. You must get family consent for a change in care plan. Withdrawal of support implies new treatments, such as palliation, for which consent is needed. No unilateral DNR orders. We must obtain consent not to do CPR. We're now by college policy obliged to provide CPR for people whose SDM requests this. If the SDM wants to do this and we don't think it's appropriate, we have to go through a conflict resolution process. And if the patient arrests while that process is going on, we should provide CPR in good faith. So, yes, Frida gets CPR, even though we feel she's unlikely to benefit from this. Let's move on. Another case, conflicted advance directives or conflicted advance wishes. Mr. H, 81, severe COPD, depression, living at home. Found by his daughters unable to communicate with a couple or a few empty morphine bottles in his room. Given Narcan on his way to the hospital, but still not able to talk by the time he arrives. Over the last several months, he had said he wanted to die as his respiratory condition was becoming more intolerable. His daughters had a legal power of attorney to make decisions on his behalf. He had requested, while he was capable, no CPR, no intubation, because his respiratory condition was getting worse and worse. There was nothing in writing, but this is Ontario. We don't need anything in writing. A verbal discussion is good enough in law. He was admitted, and over the next few hours, he developed a severe respiratory acidosis with hypertension and bradycardia. Needs to be intubated or he'll have a respiratory arrest. His daughter said, no, he does not want that. The doctor said, but the respiratory depression is as a consequence of his overdose, so we have to treat it. The family said this does not negate the fact that when he was capable, he has refused intubation should his COPD get worse. He does not want to be ventilated. He does not want to be intubated. Do not do it. More of the same. Miss M, 92 years old, lives in a nursing home, no family. She has a lawyer for her POA. She has severe arthritis. She has hypertension, cataracts, and deaf. She's otherwise well. She comes in unconscious from an overdose of hoarded narcotics. A note with her saying, I don't want to be resuscitated. My life's been good, but it's been too long. I can't do anything that I want to do anymore. Life like this is intolerable. The other gentleman said his life was intolerable too. Intolerable is a word that keeps cropping up, and intolerable is an important word here. She has one of those really wonderful little advanced directives. There's nursing home, advanced care level forms. that she signed a couple of years ago, level 4. This level 4 means comfort measures only, no medical treatment, no CPR, no transfer to hospital, and yet here she is. The nurse at the nursing home confirms that she's sharp and has her wits about her. She's fully capable. She did not seem particularly depressed recently, in fact, much more content than usual now that she's planning to leave the world. Advance directives and suicide attempts, something that we're seeing much more frequently. Over the years, there have been an increase in the number of suicides amongst the elderly, now around 20 per 100,000. There are fewer attempts per completed suicide, essentially because they're more successful at it. But the impetus to discuss advance directives and advanced care planning and have people complete some kind of planning on this throws a twist into it. I wanted to talk about this because over the last year there have been several cases like this that have come to the ethics office where an elderly person has engaged in valid advanced care planning and then separate from that, separate in time, separate in intent, has attempted suicide. What to do? Honor the advanced care planning or override it because suicide changes everything? Maybe. This is an ethical and legal very, very gray area. Although in North America, a capable person's right to refuse treatment is upheld, even if that refusal will result in their death, the law is very silent on whether a patient can commit suicide by advance directive. The assumption is that a suicidal patient lacks capacity. That's always been our knee-jerk reaction in emergency, right? Resuscitate first, ask questions afterwards. They're suicidal, they must be depressed, therefore that advance directive doesn't count. But why? Is there a legal answer? I don't have one for Canada. There have been a couple of cases in the States where advance directives have been honoured, and there's a famous case in the UK back in 2007, the Wolterton case, a young woman who had intractable personality disorder on her 10th ethylene glycol antifreeze overdose, wrote an advance directive refusing treatment, including dialysis, and was deemed capable and allowed to die, which still engenders huge debate in the ethics world. But let's look at it ethically. Who's going to override those advance directives and attempt to resuscitate Mr. H and Miss M, both based on real cases, against their express and apparently capable wishes? So this is a sort of classical autonomy versus beneficence with a little bit of guilt thrown in. The first thing to consider is that there's a prima facie duty to preserve life, whether that life wants to be preserved or not. Then we have to think about, was the patient's capacity at the time of the act impaired? 90% of suicides have impaired capacity due to depression, psychosis, or substance abuse, which means that 10% don't. And actually, does that matter? Because we're talking advanced directives here, and the whole point of advanced care planning is to make wishes known while the patient is capable for the occasion when they no longer have capacity. Then the thought that it's impulsive, they're going to change their mind, it's treatable, they're going to improve, they're going to change their mind. The other argument is that the patient might not understand the implication of the advanced directive, but that argument can equally well apply to advanced directives for everything. And then society is not going to approve of this. The law has not spoken, other than I say in a couple of high-profile cases in the USA and in the UK. And then the non-maleficence concept, the physician's sense of responsibility. Where did that morphine come from? How did they get it? Why didn't I know he or she felt so bad? Why did I fail her? What did I do wrong? How can I fix this? And on the other hand, because all ethics arguments have two hands, there are significant arguments to support honouring advanced directives in these cases. Firstly, the whole idea that advanced directives support autonomy. 10% of suicides do come from patients who would be considered rational, who would have reasons that would meet an objective standard of burdensomeness. And this has become so much more muddled by the legalization of assisted suicide, to the point that the Quebec College actually had to issue a bulletin advising its physicians that they should be actively resuscitating suiciding patients and not assuming that they were refusing consent just by their actions. As I said, We don't know where the law stands in Canada. But the main thing is that the advance directive is stable over time. It's distant from the Suicidal Act. It's presumed to be undertaken at a point where the patient was rational and capable. It's not part of the suicide attempt, unlike the psychiatric patient who writes a quick note as she's gulping down the pills. In that instance, the directive is considered to be part of the act, part of the attempt, and is of questionable validity. The main thing that gives us pause is the degree of uncertainty that surrounds the intent of the advance directive, and that's the uncertainty concept. I'm going to talk about uncertainty a lot more when I get to the made component of this. So I'm going to leave that because there's the one hand, there's the other hand, and nobody really has a finite answer to it. And move on to another wonderful thing. Feeding tubes. Frida's refusing to eat. Half the family want to give her a feeding tube. Well, the OHRI have guidelines outlining the medical benefit and burden of feeding tubes and whether they're a good idea in this patient population. And the answer to that is generally not, from a medical point of view. But the ethics of it all, like all ethics, is a lot more tangled. We talk about the principle of proportionality, which is just a high-sounding way of saying, is the benefit enough to outweigh the burden? Is there enough utility in it to make it worthwhile? So again, we're talking about whose futility is it? We know it may not be medically useful, but sometimes the best interest argument is not purely medical. Feeding has emotional, societal, and relational value also. We also have to bear in mind that when we discuss a treatment, we sometimes create an expectation just by bringing it up. It's perceived we proposed the treatment. Then having proposed it, we have to backtrack and say, no, we were just talking about it. We're withholding this particular option because of medical evidence. So at that point, we've already entered into the conversation, and we're now proposing an alternate treatment, which is palliation, that requires consent from the family. And if the family doesn't consent to that, then we're sort of stuck into this conflict resolution cycle. It's worse when we actually even consider stopping enteral nutrition. This is another sad case of an advance directive refused. This was in BC in 2015. Margot was a retired nurse who looked after dementia patients, so she knew which of she spoke. She wrote very clear advance directives, authorizing her husband and daughter to be her medical proxies, which is the BC substitute decision-maker power of attorney. That when she no longer recognized her family, I direct that I be allowed to die. No CPR, no breathing intervention, no nourishment or liquids. Pretty clear. She had severe dementia, lived in a care home, didn't recognize anyone, and was pretty well unresponsive except when someone held a spoon up to her mouth, she opened it. Her family wanted to honor her wishes, that she should not be fed. They even wanted to take her home to palliate her at home if the care home couldn't follow her wishes, which they said they couldn't. But the health authority insisted that police be called to prevent the family taking her home, so the family went to court. And the judge ruled that by opening her mouth, she was consenting to be fed, and that feeding by spoon, unlike tube feeding, is not medical care, but personal care, and not covered by an advance directive. They went to the BC Court of Appeal, who dismissed the family's appeal, and she died in late 2017, 17 years after diagnosis of her disease and 5 years after the onset of the court proceedings. But wait! What if Catherine, Margot's daughter, had said, we have this wonderful new thing, medical aid in dying. Margot's advance directive also said she wanted to be euthanized when she could no longer recognize her family. Can we do that? And the short answer is no. Bill C-14, almost 2 years old now, allows medical aid in dying, and it still polarizes the medical community. Over age 18, a grievous and irremediable condition, serious incurable illness or disability, advanced state, irreversible decline, enduring an intolerable suffering. This is why the intolerable component is worse. If Mr. H and Mrs. M had applied for MAID, they would have been eligible. Natural death reasonably foreseeable. Sounds like Margot, yes. Signed written request, can withdraw at any time. Can withdraw at any time, that's important. 10-day waiting period, shorter if death is imminent or capacity may be lost. Capacity may be lost. The patient must have capacity at the time of the request and at the time of the procedure, so they have to have the ability to change their mind. It's currently not available by advance directive, and it's unlikely to become so. As soon as it came out, there were lots of court challenges going on around it, right from the get-go. EF in Alberta obtained permission from the Supreme Court to obtain MAID for a conversion disorder, not fatal. Bill 84 in Ontario normalized assisted dying, so it's no longer registered as suicide. And last year, AB helped clarify reasonably foreseeable in a geriatric case, an 80-year-old who requested MAID for osteoarthritis, which is not fatal, but not imminently dying of the osteoarthritis, but had multiple other comorbidities, and it was the collection of comorbidities. Think surprise question. So how about MAID by advance directive? Remember this movie, Still Alice? She intended to take all of her pills when her dementia became bad enough, but then became distracted and forgot. She still had some quality of life. So the big debate around medical aid by advance directive is the uncertainty of intent. So we get back to the uncertainty argument again. So now we have the long-awaited Council of Canadian Academies report. They finally came out with their 600-page report, which was billed as recommendations, but very carefully made no recommendations at all. 43 academics from various fields spent 2 years looking at all aspects of MAID, legal, clinical, societal, practical. They said it was complex, conflicted, agreement could not be achieved, there were significant differences of opinion, no one could agree. Essentially, they looked at how an advanced request for MAID is different or similar to an advanced directive for healthcare under existing provincial and territorial regimes. And the answer is very, very different. Advanced care planning is, I do not want this form of life-sustaining treatment. Refuse it on my behalf if I'm ever in the position when it's offered. The disease process is calling the shots. It's time for dialysis or a vent or CPR or whatever, and I don't want it. There is a degree of certainty. An advanced request is, at some point in the future, a set of criteria will be reached where I want to be helped to die. But a third party is going to have to interpret when to enact this. The patient can no longer confirm that they want it, and they can't confirm that those criteria have been reached. It's a legal quagmire. Allowing advanced requests for MAID would require amending the federal law. It would have to be implemented under provincial healthcare consent acts. Advanced directives aren't legally binding, but advanced requests would actually have to be legal consent for a procedure with all the same rules for consent, capacity, voluntariness, informedness. Could they be informed of alternate treatments if they don't actually have anything requiring a treatment at the time? How voluntary is it? The uncertainty factor. That third party, whoever they would have to be very clear that MAID really supported the patient's ongoing goals, that now is the moment that fulfills the criteria. Margot said, I want to die when I don't recognize my family. Some of them, all of the time. And are you sure that the new person that exists now still wants this? She may not recognize her family, but finds pleasure in some experiences. The new person may have subjective experience and can express wishes and preferences. And how can anyone ever fully comprehend someone else's intolerable suffering? They looked at what would strengthen the argument, provide increasing clarity. Has the patient described very, very clearly what the criteria are? Have they clearly attained those criteria? Do they still have a desire for MAID, and do the family and healthcare team support this? But there are far too many intangibles. I looked at 3 distinct scenarios. The first one, where a patient is eligible at this point, but they are afraid that they might lose capacity before this is implemented, like the very recent, very high-profile Jacky Parker case in the press. And 2 more where a patient has a disease where they may lose capacity, and the very, very loosey-goosey, well, maybe at some point in the future, but I'm quite healthy at the moment. And at the end of the day, they passed it back to the government with the final words that consensus is unlikely. So made by advance directive, not anytime soon, not happening. So basically, not doing anything is a treatment requiring consent. Don't withdraw care of the SDM's objections. Don't start anything you might want to stop without setting out parameters for stopping. Stop now. When the patient has capacity, they can't defer to an SDM, although they do. You don't have to provide care that's futile, but who defines futile? Take your conflicts to CC&B. Don't expect they're going to find in your favor. Document everything. Speak Up Ontario is great for advanced care planning. Chilo is a good tool for working through what to do to fulfill your legal and ethical obligations. Look at the Serious Illness Conversation Guide. If you can get into one of the internal medicine teaching groups, it's great. And MAID is slowly evolving, but it's not going to happen by advanced request at any point in the near future. And questions. Thank you. And that's